Okay, let's start. Hey everyone, and welcome to RaySearch webinars. Today we will have the first episode of our new series on advancing re-irradiation. In this series, we will bring together experts from RaySearch and from leading clinics around the world. We will explore the latest advances in re-irradiation planning and how they can help us to take safer and more informed treatment decisions. We aim to showcase new features in RayStation, practical clinical workflows, and case examples. This series will be given in 3 episodes, this one and 2 more that will be held during the autumn. So my name is Stina Svensson, and I will be the moderator for this first session, which is Reirradiation in RayStation, planning with cumulative eco-effective dose in 2 gray per fraction in 3D. And on this one, we have presenters both from RaySearch and from a clinic. Before I introduce them, I want to talk a little bit about you who are listening. I checked 1 hour ago, and then we had 634 registered from 59 different countries all over the world. That's really nice to see. Of course, not all of you are here watching this live, but maybe you will watch it afterwards. We asked some questions in the registration form. The answers clearly showed that re-radiation treatments are happening in almost all clinics. 95% of you answered that you're delivering them either routinely or in selected cases or trials. If we look at the hurdles for the moment, according to you, we see that many of you consider uncertainty in dose accumulation and image registration accuracy as the biggest one. After that, it's rather evenly spread between different categories. We will have a Q&A session towards the end where we will answer some of the specific questions that you have. I know that the presenter aims to embed answers to many of them in their presentation, but if we have some leftovers. In the Q&A session, you are also welcome to add additional questions, and you can do that using the Q&A function in Zoom. You will find that in the toolbar. So if you go to press the 3 dots for the more, you will find the icon there. We will try to answer as many as possible during this episode, either in writing or in the Q&A session. So now over to the presentations. We will start by diving into the functionality in an upcoming RayStation. We will hear Rasmus Krantz, who is head of algorithm development, and Jakob Edén, senior research engineer. They will guide us through this to what you can do with respect to re-irradiation in RayStation in this upcoming version. And then Louise Murray, associate professor in clinical oncology, and Chris Thompson, principal clinical scientist from Leeds Teaching Hospital, will describe how the tools can be used for some clinical re-irradiation cases. We have a research collaboration with a group in Leeds on re-irradiation. We've had that for many years, and this has been really essential when implementing the functionality to get the tools in that are actually needed in the clinic and to do it in a way which allows for a safe and efficient workflow. Yes, so let's start with the presentation. I leave the floor to RaySearch team, and I think that Rasmus is the first one out.
Yes, thank you, Stina. So please share my screen. So I will begin by and briefly introduce re-irradiation before leaving over to Jakob for the actual product demonstration. And throughout this presentation, we will use the consensus definition of re-irradiation from Estro, which states that reirradiation is radiation therapy delivered to a previously treated region. That is then subclassified into type 1 reirradiation, where you irradiate with a geometric overlap against a previously irradiated volume. And then there's also reirradiation type 2, where there's no geometric overlap with a previously irradiated volume, but the new target volume is still sufficiently close to a previously target for there to exist a concern about toxicity from cumulative doses. And there has been quite a dramatic increase in clinical use of this form of treatments over the recent years, as illustrated here by some data from our partner clinic in Leeds, which shows that reirradiation treatments more or less were not performed 15 to 20 years ago, and has then steadily increased in clinical use and is now very much a standard treatment option. And this development is, of course, due to multiple factors. One important factor being that cancer therapy in general has improved, which means that cancer survivors will live longer and more cancer survivors will experience a recurrence of their previous disease or receive a new primary cancer that requires treatment. And when it comes to the actual radiation therapy treatment, we have also seen, of course, large technical advancements made over this time period. The use of IMRT and VMAT has become more widespread, which deliver highly conformal fields. Image guidance has improved. Stereotactic treatments are becoming more common, as well as adaptive strategies. And altogether, these improvements make reirradiation a safer and more feasible option for treatment than it was previously. This slide here shows some actual numbers on how large fraction of the total population that the reirradiation patients constitute. And the graph in the upper right corner is from a study across all cancer centers in Denmark, where it was found that 18% of all patients treated in Denmark in 2023 received at least one retreatment course. And about half of these retreatments satisfy the criteria for reirradiation, according to the Estro definition. And quite similar numbers are reported in a publication from the University of Michigan, where it is stated that in recent years, in between 10 to 17% of all their treatment courses required an additional consultation due to the patient having received a prior radiation therapy course. And there are also other institutions that report similar reirradiation rates of in between 10 to 20%. Another interesting number is perhaps also that there are roughly 100 currently ongoing clinical trials on reirradiation. So this is clearly a very active area, both in terms of research and clinical use, but it also comes with many technical challenges. And one challenge is, of course, the logistics related to retrieving information about the prior treatment to take into consideration when generating the reirradiation treatment plan. And DICOM data is not always available, and even for the situation when you do have access to DICOM information about the previous treatment, then there can still exist inconsistencies in naming of structures and other contouring conventions, which makes it difficult to find a matching between corresponding structures across data sets. And then there are, of course, also considerable anatomical changes to take into consideration. And these can be very large for reirradiation that sometimes occurs years after the initial treatment. So it's not uncommon that the patient anatomy has been subject to considerable morphological changes, for instance, due to organ motion, but also weight loss or weight gain, radiation-induced injury, or even surgical interventions. And all of this needs to be accounted for somehow in the assessment of the cumulative dose. And then a third very important factor to take into account is the radiobiology. It is well known that the biological effect of radiation is not only dependent on total dose, it's very much dependent also on how large doses that are given within the individual fractions. So it is not in general biologically meaningful some physical dose or RB dose in the case of ions across multiple treatment courses. Certainly not if the courses have different fractionation schemes, but even if you sum doses across treatments with similar or equivalent fractionation schemes, you might still have drastically different doses in between fractions for the organ at risk. So what one should do is instead to account for the fractionation differences and convert the physical dose into some form of equieffective dose. And the equation here to the right illustrates conversion based on the LQ dose response module. Here with a general reference fraction size denoted X, which is very commonly set to 2 gray, yielding EQD2, or sometimes set to 0, which gives BED. And then there's an alpha beta ratio that takes the fractionation sensitivity of the tissue of interest into account. And it's also fairly common to introduce a scaling of this equieffective dose, such that a fraction of the equieffective dose from the previous treatments is disregarded. And this in order to account for the fact that there is evidence showing that tissues can partially recover over time from the previously delivered radiation. So at a high level, the approach taken within RayStation to address these challenges will be illustrated here. So what we look at right now is, in some sense, the naive approach to cumulative dose assessment, where one simply sums physical doses across the 2 treatment courses. In this case, this is a pelvic case from a joint study with leads. But this is not what will be done in the upcoming RayStation version. Rather, instead of accounting for physical dose directly, we support, as I mentioned previously, conversion to equieffective dose in 2 gray fractions based on alpha beta ratios and tissue recovery factors set on per ROI. And then the dose summation also relies on a mapping of the dose from the prior planning image to the reirradiation planning image based on a deformation vector field calculated by deformable image registration, which is able to account for the anatomical changes that has occurred in between the 2 treatment courses. And this approach is very much in line with consensus recommendations that have been published very recently. So one example is this decision tree shown here to the right from the Reirradiation collaborative group, which essentially states that when assessing cumulative dose, you should do that by performing image registration based accumulation of equieffective dose in 3D, if that is technically feasible. This publication also mentions EQD2 or BED as the 2 default methods for computation of equieffective dose. It highlights the use of organ-specific tissue recovery factors as often being appropriate, and it does not contain any statement on appropriate registration strategy, but it highlights the fact that it is absolutely necessary to assess the accuracy of the registration technique that is used. And then there is also a recommendation made by the Estro Reirradiation focus group, also publication from earlier this year, with quite similar recommendations. Again, the recommendation is to assess cumulative equieffective dose summed in 3D using image registration techniques. This study goes one step further and recommends that deformable registration should be used instead of rigid registration for disease sites where the anatomical changes are typically quite large. And that recommendation is, of course, based on evidence such as this study across 6 cancer centers in Denmark. This is a pre-trial assessment in preparation for a clinical trial on lung cancer patients, where deformable image registration was compared to rigid registration, and it was found that the deformable approach yielded a significant improvement in accuracy in terms of transferred organ at risk contours onto the reirradiation planning image. That also led to a smaller spread of cumulative equieffective doses as over the different participating centers. Thank you. So I will leave over to Jakob then.
Thank you, Rasmus. I'm sharing my screen. Yeah, so now we'll go over. Thank you for the introduction, Rasmus. He has introduced most of the concept. Sorry, I lost my slide. So now we'll talk about the planning of 3D cumulative EQD2 in RayStation and based on these concepts that Rasmus just told us about. So we'll focus on the reirradiation workflow in the treatment planning system in RayStation in this case. But of course, as Rasmus mentioned, there is a lot of things going on already in the oncology information system, preferably RayCare in our case, to retrieve information and to handle this. But I will focus, as I said, on the treatment planning workflow here. So we envision a treatment step of about 7 different steps. So first you will configure your data, you will do your image registration, you will create your plan, you will connect it to the prior treatment. And as Rasmus told us, we will then define this RI-specific EQD2 parameters, such as the fractionation sensitivity, which is the alpha-beta value in this case for the LQ model, and the tissue recovery factor, if you think that there is a long-term recovery for different organs. And then we will define optimization function, clinical goals, and do plan evaluation, everything based both on those EQD2 or EQD2 with tissue recovery, if needed. So in RayStation, then this workflow really spans of the whole workflow. So you can see these several bullet points. If you look at in RayStation, you might recognize the top that we go everything from patient data management through patient modeling, plan design, plan optimization, and finally plan evaluation. And some important note here is that we will support one prior treatment in the upcoming version, and that we actually support all modalities directly. So this means that protons, carbon ions are also supported, for example, not only photons. The only thing that we don't support in this upcoming release is B and CT. And also it's important to know that we support plans with one beam set for reirradiation. Okay, so first then, configuring your prior treatment data. First, of course, you need to access these data. And in RayStation, then we support treatment cases, and we actually support 2 different approaches here. So either you would have your prior treatment and your reirradiation treatment in the same case, and then automatically all data is accessible. But what we prefer, and I hope that what many of you also prefer, is that they actually separate these treatment cases. So you have the prior treatment in one treatment case and the reirradiation in a separate treatment case. And if you have this case, we need to access, of course, the data in between the cases. And this has actually been supported since last version of RayStation, where you can access the previous image. So you can see here we have a reirradiation case, and then we want to access the previous case, which is a pelvic treatment. In this case, it's a prostate treatment, 60 gray. And then the functionality access this treatment from the previous case into the new case, and you have access to all the image data needed. And you will also then be possible to associate ROIs and points of interest between the cases so that you can use them, for example, for deformable image registration to have them as structure guidance. And you will also access then the treatments from the prior treatment case to use them as prior treatments in the reirradiation planning. And then the next step then obviously would be to do this deformable image registration. And here we support 2 different algorithms in RayStation. We have the Anaconda algorithm and the Morpheus algorithm. Whether you will use it, you will in both cases start with a rigid deformation, rigid registration, which means that you will do the translation and the rotation needed to match the image. And here you can see an example of this pelvic case. You see that there's a huge deformation in the bladder because of different filling, but also the rectum is quite differently. So the rigid registration in this case obviously is not really showing this to capture this deformation. So then we can run one of these algorithms. In this case, it's an Anaconda algorithm who's run, and then you get this deformation vector field. And you can see the magnitude to the X going from 0 up to 4 centimeters with this vector. So you see that they have the largest deformation indeed in the bladder region here because we have a large deformation in this region. And you can see there's also some deformation in the rectum region. And then we can actually apply this vector field to the anatomy. So if you do this, we will then deform the anatomy according to this. And then you see that the bladder now and the rectum actually deforms quite well to the previous, along the new image, to actually map the structure between. Of course, as Rasmus told you, we know that there are some uncertainties in the deformable image registration. So of course, it's very important to actually assess this. And we support a lot of different tools. We will not go into detail in this presentation here, but there are, of course, the guidelines on this also internationally, that you should, of course, do visual alignment. You should check on the deformable vector field to see that it's non-physical. And you should, listen to this physical, so look for foldings or distortion, and also probably propagate your structures and compare to the reference contour on the new image using dissimilarity, Hausdorff distance, mean distance to agreement, or some other metrics that you're interested in. And you can, of course, also take it even further to like perform, to check at the Jacobian determinant, to check for the unreliable deformation, but also run multiple deformations to check for consistency and robustness. And as I said, all these kind of tools are supported in RayStation, and you can also, of course, script them and make customized script for this to do your assessment as you wish to do it. And when you have this deformation done, then we're ready to actually perform and create our reirradiation plan. So we have then a regular reirradiation plan, a regular RT plan in RayStation, and then we add this prior treatment. And then what we get then is what we call a reirradiation plan. And you can see that there's a different icon for this in RayStation, showing that we have knowledge of prior treatments. And again, just what I emphasize, that this is actually supported for all modalities except the BNCT. A prerequisite for this is that you have approved your prior treatment plan, and then you have a deformable image registration, and you have selected this for dose deformation. Then a little talk on the prior treatment, and we actually support quite a lot of different prior treatments. So obviously we support regular RayStation plans, and this can actually be from any modality. So you can actually connect the photon plan with a proton plan and vice versa. And we also even support adapted plan as prior treatments. And also we, of course, support RT and 3D doses. So this can be from another treatment planning system using DICOM. And we have new functionality then. We know that if you import it, it will be set to 1 fraction. So what now is implemented in the upcoming release is that you actually, when you import your treatment, you will actually select the number of fractions. And then the dose will automatically be scaled according to this. And this is what we're going to be used for the EQD2 conversion. And in fact, we actually support any 3D dose distribution, as long as you have it in the treatment plan in RayStation and you approve the plan. The next step then, as Rasmus also told us about, we want to define these EQD2 parameters to perform the cumulative EQD2 dose. And this is then RI specific, alpha beta values, and the recovery factor in percentage, which is then the long-term recovery between the treatment courses. And then under the hood, we will actually calculate parameter-specific EQD2 distributions. We calculate one EQD2 distribution on the full dose grid for all pairs of alpha, beta, and TRF. I will show you a bit more on this later on. But how it looks like for a user is that you specify a table. So you have your RIs that you're interested in, you specify the alpha, beta values, and potentially tissue recovery. This is then a percentage between 0 and 100. And here you see that we're connected to this pelvic treatment, the prostate case of 60 gray. And you then, the RIs that you don't define, they will automatically use the external default values, as you see stated in the here. So RIs that are not specified explicitly will use the alpha beta value 3 in this case. However, all the RIs that are evaluation, like on DVHs, those statistics, and clinical goals, will use these parameter-specific EQD2s. And this is for DVHs, those statistics, clinical goals, and also for optimization functions. So this means that we don't have to bother about any overlap between different tissues, because we use an underlying distribution only accounting for the specific alpha beta values for the specific ROI. However, if you want to visualize a 3D dose or a 2D dose, we need to superimpose them. So then we need to bother about this overlap or different, which one has priority over the other. And that's why we have this display order also, as you said. So you can see this is an interactive video where I changed the display order. So I changed the priority then basically on the external in this case. And if you see closely, you see that the EQD2 here is actually changing within the bladder, the rectum, and the sacral plexus here, while I change this. But you might notice that the parameter-specific DVHs are not affected by the display order. They will only evaluate using the correct alpha beta values. It's only for visualization that this display order has an impact. So now I will show you a small video from RayStation. So I will show you how it looks like when you add the prior treatment and also define your EQD2 parameters. So now we are in RayStation. We have a treatment plan dialog open. This is a reirradiation. It's an SPRT case of this pelvic treatment that also Chris and Louise will talk more about later on in this presentation. So it's a 5-fraction 30 gray defined to the lymph node of a reirradiation in this case, and the prior treatment is then a 60 gray prostate case. So if you're familiar with RayStation, you might see that there's a new part of this dialogue here. So we have prior treatments, and you see currently this plan has no prior treatments, but we have a button here to be able to add this. And now we will access a plan from a different treatment case when I start playing the video. So now the video is running, and you see how we use the button Add Prior Treatment. When we use this, you see a dialogue open, and here we can access the previous pelvic treatment in this case, which is an approved plan. Then we just press OK, and then to the bottom you see we get all this information directly into the treatment plan. And then we can move on to the new EQD2 tab, and now we're going to define our EQD2 RI-specific values as the alpha beta values and the TRF for all the tissue. And this is exactly the same values as you saw earlier for this pelvic treatment. So you see we defined alpha beta values and the recovery factors as we wish. And then we press OK. And now automatically the plan is connected to a reirradiation plan with alpha beta values and tissue recovery factors. So you might also notice that the equations here, if you're uncertain how the TRF is used, for example, you see that the TRF is actually 1 minus the TRF multiplied with the EQD2 to get the EQD2 TRF, which is then the recovery corrected EQD2. Okay, so moving on then. So actually, when you have done this setup, you have the prior treatment and your EQD2 parameters. The prior dose is actually automatically transformed or mapped to the new CT image. So you see the prior image and the prior dose, and here you see the deformed dose on the new image. And then you can compare, for example, the different DVHs. You see full line is prior dose on the prior CT, and the deformed dose is the dashed line then. And as I said, automatically you also get the conversion with ROI specific according to the table that you just defined. And here you can assess then the dose or the EQD2, how the mapping is actually influenced this. And this is, of course, very important as well to assess this, how the mapped dose and EQD2 is transversed from the old image to the new image. Look for high dose gradients compared to the deformable vector field. You can also repeat this with different settings on your deformable administration to assess robustness and so on. And this is, of course, also supported. So the next step would be to actually plan your treatment. And here we have a new functionality in the upcoming release of optimizing a cumulative EQD2. So you can actually combine optimization both on the plan and the cumulative dose using EQD2. And this is then highlighted here in the optimization function dialog, where you add the function. So you select plan dose or plan plus prior treatments dose, which is then the cumulative dose, if it should be dose, EQD2, or EQD2 TRF. And we also have a new functionality here. So when we actually optimize on the cumulative dose or the cumulative EQD2, the dose level is actually adapted to the heterogeneous prior dose while we're optimizing to make sure that we don't seek for example, for negative doses. And also highlight that we actually support robustness in this. So you can optimize robustly on cumulative EQD2. However, note then that the prior EQD2 is always treated as fixed in all scenarios. So you only vary the reirradiation dose during optimization. And when you have an optimization problem like this, you can then combine, so simultaneously optimize on plan dose and on cumulative EQD2. So for example, you can make sure that you have coverage in dose for your reirradiation target while you control the cumulative EQD2 to your risk organs. And this is then shown here. You see that the column dose here, some of the function of the PTD, for example, acts on the planned dose, whereas some of the risk organ doses actually act on the cumulative EQD2 for the bladder, rectum, and sacral plexus it is. And this is then a support, of course, with dose, EUD, DVH, whatever you want. And if you mouse over this icon that you see on the EQD2 function, you will actually access then which alpha, beta, and TRF parameters are actually used. And again, they are connected then to this table that you have defined for this plan as a user. And for evaluation then of EQD2 and also the plan itself and for the cumulative dose, we also support cumulative EQD2 clinical goals, similar to optimization function. Then you can associate the plan either to the cumulative dose or to the plan, and you select if it's going to be dose, EQD2, or EQD2 TRF. And then a goal list could look like this. So we have the first grouping of the cumulative dose. You see we have bladder, rectum, sacral plexus, and vessel have clinical goals defined on EQD2 or EQD2 TRF. Whereas we have plan-specific goal to make sure that we cover the target, for example, in this case, in physical dose. And just to highlight something here is to show that we have an identical clinical goal for the rectum in this case. The only difference is that we account for recovery in the first one, 25%, according to what you have defined as user, and 0%, of course, in the other one. And you can see the dramatic difference here is 15 gray difference in the near maximum dose, only then attributed to the recovery. And the same thing you can actually see for the sacral plexus in this case, but here you see that it's actually 50% recovery assumed, but the difference in the cumulative dose, EQD2 here, is minimal. It's only 1 gray. And this is, of course, because all of this dose is coming from the new plan and very little is coming from the previous plan. So these things you can access directly with clinical goals. And the next thing then would be, of course, to evaluate the plan using all the existing functionalities such as DVHs, those statistics. You can perform deformation or perturbed and some evaluation doses. And you can, of course, also look at the 2D and 3D dose evaluation, both superimposed and these parameter-specific EQD2s. So in the plan evaluation tree, what you have the plan dose, then you will see the EQD2, but then you have a new box here, including the cumulative doses and the prior doses. So if we open this box, you can see that we actually have the cumulative dose, plan plus prior treatment dose, but also the pelvic treatment. So this is our prior treatment. And this is then in physical dose, since this is photon plans. Otherwise, it would be RB dose. And if we open this, you can actually see that we have under the cumulative dose, we actually have both EQD2 and EQD2 with TRF. And of course, this is superimposed doses, so it's according to the plan display order that you have selected as a user, which you can, of course, interactively change, as I showed you in the video before. But then we can take it even one step further, so we can open the box of EQD2, and there you see under this is actually have all these parameter-specific EQD2s. So you see we have one distribution for each alpha beta values here, reflecting the actually doses that are used for evaluation of DVHs and clinical goals. And the same thing applies then for the cumulative dose. We have all these different alpha beta values under the hood, which you also can display as a user. And we even have the TRF distribution, so EQD2 with the recovery. And you see that this is all combination for the different RIs that you have specified as a user. And then in evaluation, you can, of course, compare this. So, for example, you can compare the cumulative EQD2, which we have on top, compare it to the cumulative EQD2 with tissue recovery, which you have below. And this is according to the user-defined recovery. And if we then look at the dose differences, you may see that we only have differences, of course, in the RIs that we have specified recovery. So in this case, bladder, sacral plexus, and the rectum. Whereas you see there's no dose difference outside of this because we have assumed no recovery there. You can also then compare DVHs to see how much the recovery affects, for example, and also look at the cumulative EQD2 with and without the recovery. And of course, you can also assess the clinical goals. So now we've gone through all of this workflow that we have in RayStation. But of course, as always in RayStation, we support this with Python scripting. So this means that you can customize and streamline and even automate your reirradiation workflow in different steps. I will show you some brief videos of how you can do this. The first one is a real advanced one where you have your deformable illustration performed already. But in the script, we will add the prior treatment, add the EQD2 parameters, clinical goals, optimization function, and then optimize our reirradiation plan all in one click. But we, of course, know that some people don't want to optimize the plan based on the cumulative dose. You might just want to evaluate the clinical goal and the dose distribution of the cumulative EQD2. And then we also support, of course, that you can do regular RT planning, and then afterwards add your prior treatment, define your EQD2 parameters and cumulative dose and cumulative clinical goals, and then assess it. So this I will also show how you can do. So the first script now is an automated reirradiation planning. So we have a treatment plan. There is no dose. Again, this is this 5 fraction of 6 gray for this pelvic treatment. And when I start the script, you will see that we will just press one button from a loaded script. And now everything will just, now you see the EQD2 parameters is added, the prior treatment is added. You see all the clinical goals there is added. And now the optimization function is added. And here you can see that we combine planned dose, so only physical dose for the different lymph node targets that we have seen here, PTV1 and PTV3 in this case. And we have a fall-off function. We actually have an EQD2 function working only on the planned dose as well for the sacral plexus to actually optimize EQD2, but not accounting for prior treatment. And then we have a number of cumulative EQD2 function on the bladder, the rectum, and the vessels. Now you see that optimization has started. So now we see the physical dose only from the new plan. And so you see that we start to get conformal dose distribution around the black squares, which is this lymph node now. So now 80 interaction has happened on the optimization. Then we can go to plan evaluation. We can evaluate our clinical goals. You see that most of them are fulfilled. Some of them are yellow in this case. And then we can assess all the doses that I just showed you. So now we compared the cumulative EQD2 on top with the cumulative EQD2 with tissue recovery on the lower half. And then you can assess differences with DVHs, but also with the difference view, as you see. And you can change the display order here to see how this affects the 3D superimposed distribution and so on. Okay, and the next script here is very fast then. So here is just the automated reirradiation evaluation. So now you have a treatment plan. You just want to add the prior treatment, add your EQD2 parameters, and do the evaluation. So you see, I have highlighted with 3 boxes here what will happen, actually. So you see that there is no cumulative dose. But when we start the script, you will see that we will add a cumulative dose as soon as we have a prior treatment. So now you see, now we have a cumulative dose. EQD2 parameters has popped up. And when we press this, you see they are populated, we get the clinical goals, and now the script has ended. And now you get all the cumulative doses again, and now you can start comparison and evaluation in the VHS clinical goals or whatever you want. So to summarize then, the upcoming release of RayStation, we have really tried to target the key features that have been requested in the literature. So for example, from the astrophysics workshop and the recog meeting, the highest priority from the people in the clinic is to have cumulative EQD2 effect calculation and visualization with organ-specific alpha, beta, and recovery, and also to be able to optimize on the cumulative EQD2, which you now can. And we hope that this will support clinical feasible reirradiation planning at scale according to clinical guidelines, as Rasmus told us about. And I hope that this means that we can account for prior doses in EQD2. We can bring optimization on cumulative EQD2 to the clinic, and hopefully we can get more consistent reirradiation planning for all treatment modalities. And of course, we want to acknowledge our collaboration with Leeds. We have a number of publications. If you're interested, you can see them to the right. And we also have an initial validation of the software approach together with Leeds, Manchester, and Newcastle, which was an ESTRO presentation this year and hopefully become an upcoming paper. So with this, I will actually leave to our collaboration partner from Leeds. So I will leave to Chris and Louise. I think Chris will start.
Yep, Chris is going to start. I'm just going to introduce myself. So my name is Louise Murray. As Stina said, I'm a clinical oncologist in Leeds, and I'm interested in reirradiation on the research and on the clinical side. Over to you, Chris.
Yeah, hi, I'm Chris Thompson, also from Leeds, a physicist, working 50% as research due to some RadNet funding we've been lucky to get. And we've been working on this collaboration, as has been mentioned. So I'm going to start, and I'll start by talking about a pelvis patient that Jakob's kindly shown you so far. Just go through some of the decisions and pathways you might like to consider as you use this new tool. And then I'll hand over to Louise to sort of go through a brain case. So if we imagine we've got this case presenting to us in clinic, they've previously had this historic treatment. Immediately you'd be considering that maybe the rectum is an organ of concern for any sort of repeat treatment. So when you look at the new PTVs that we've got, unfortunately one of them is right next to the rectum, and you can see there's one that's not particularly near any organs at risk, so probably won't pose too many sort of challenges. So normally, if we were doing this plan without the new tools, we'd be finding a physical dose on the previous treatment, converting that into EQD2, and then using that number to sort of subtract from our limit and come up with a new limit to plan with. But the new tools, as Jakob's mentioned, obviously rely on using a mapped dose. Now, not everywhere has got deformable registration sort of commissioned. So in that case, I suppose you would be trying to do a rigid registration and maybe focusing on the rectal wall as a sort of matching structure. Or if you weren't happy, maybe particularly in the pelvis, like Jakob said, you may go back to doing a sort of point dose assessment initially. But then you can still use all these EQD2 tools to sort of remove some of those manual calculation steps, which would also sort of streamline your processes. Though in this case, though, we sort of quite happy that the registration was okay. We used the rectum as a controlling structure, and we could also see the dose gradient is reasonably moderate between the PTV that we're going to try and treat in the rectum. So that's sort of also given us some confidence. So we can go ahead and set some objectives. We've made that plan, the background dose, as has been described. We've added our clinical goals. We're not sure whether to use a rectum PRV or not, so maybe we'll do a plan with both, so we can show our clinician colleagues so they can make a decision based on sort of risk due to organ filling. They may be slightly cautious. So as you can see, we've got the plan plus prior treatment clinical goals at the bottom. We've set up 2 for the rectum, just so you could see that we'd probably use the same values. And the EQD2 is basically the total dose limit that we want to achieve for that organ. So then to do this, because we're obviously limited to a single beam set, but we've got 2 PTVs, we're going to need 2 beams. Luckily, we can use the treat margin function to limit the beams to the relevant PTVs so that they're not sort of treating tissue in between the 2 targets. As you can see there, we've used a treat margin of 5 millimeters, assigning beam 1 to target 1 and beam 2 to target 2. And also we've gone for fairly simple alpha beta options. We're just basically setting 3 to the whole patient and 2 just to the sacral plexus, and we've gone for no recovery. So our rectum's going to be done optimized using an alpha beta of 3. So when we don't use the PRV, our plan looks quite nice, but we were maybe slightly worried that the high dose is quite close to the rectum. Maybe we wouldn't be quite happy with that clinically. And if we look at the summed total EQD2 doses that we can review during the optimization, we can see that our mandatory and optimal clinical goal isodoses are quite close to our rectum in this case. So maybe we go ahead and we plan again using the PRV to try and push those doses slightly further away. And you can see we've pushed it just till we're starting to lose coverage. Maybe this isn't, yeah. But we can also, during optimization, we can see the clinical goals, and we can take action during optimization to ensure that we achieve the clinical goals that we're trying to by pushing our constraints and interactively optimizing with the plan to meet them. And you can see there we managed to achieve the PRV below the mandatory, slightly above the optimal, but we've still got coverage on both targets. And eventually we come up with 2 different plans to show our clinical colleagues, where we've got high doses quite close to our PTV, and the other one where we've created a bit more sparing. So it's over to Louise maybe to make a call on which one she'd like to use and talk about the brain.
Thank you, Chris. So as the treating clinician, I've been on set with these patients, and I know that the rectum can massively change in size and shape between treatments, even within a treatment. And so for a cautious reason, I probably would favour the plan that uses the PRV. And that would mean that the coverage isn't quite so good, but we're still getting coverage on our target. And I think particularly in the case of a patient with recurrent prostate cancer, where we believe that the alpha beta of prostate cancer is low, we're still giving that patient a very good high dose. So I would favour the PRV. So thank you, Chris. I will take over, and I'll now move on to talking about a brain case. Here we go. So this was a case that I came across almost 10 years ago. It was a chap who was in his 60s who presented with headaches and seizures, and he had this scan here which shows a huge cystic mass in his right hemisphere of his brain in keeping with a primary brain tumour. So he underwent debulking surgery, and the pathology revealed a glioblastoma, so a very aggressive, incurable brain tumour. As is standard after surgery, he was planned for 60 Gray and 30 fractions of radiotherapy with concurrent oral temozolomide chemotherapy. And here's his original treatment plan. This is fairly typical for the time. So wide margins around our GTV, large PTV treating a large proportion of the brain, a lot of dose to a lot of the brain, but you'll note that there's some sparing of the brainstem, as we would expect, to keep the brainstem in tolerance. So that's our 60 and 30 original treatment plan. 2 months after that, unfortunately, his disease began to grow again, and so he had further oral chemotherapy, as is commonly used. That worked for a little bit, but then unfortunately he progressed again. And this time the tumour, interestingly, progressed in a different site. You can see this little splodge down here, round about the fourth ventricle near the posterior fossa. And it's unusual to progress at a distant site, but that's what he did. And he was very symptomatic, unsurprisingly, because of that location. He felt very sick. He was off balance. He wasn't able to walk. And so the clinician who was looking after him, because it was at a distant site, said, well, let's give him more radiotherapy. It will be palliative, but because it's so far from his previous treatment, let's give him very high dose palliative radiotherapy, so 30 Gray and 6 fractions. That was the original intention. That clinician then disappeared and he came to me. And I said, but what about the previous treatment and what about the previous dose to the brainstem? And I could get out his old plan and I could see that the highest dose to the brainstem was just under 53 Gray. And I could work out that it was unlikely that the highest dose from the second course would be exactly where that 53 Gray was, but I couldn't see exactly what dose went where in terms of the brainstem. And it was about 9-10 years ago, and nobody would help me. And I was unable to get the original treatment plan co-registered with my new reirradiation target. And so I discussed it with my colleagues, and we couldn't safely work out what dose went where. So in the end, we dropped the dose right down. We decided to give 20 Gray and 5 fractions because we thought that will treat the tumour to some extent, but it has to be safe in terms of the cumulative brainstem dose. Surely that will be okay. So this is my reirradiation target. You can see it overlaps with the brainstem. You can see that in both planes. And this is what I wasn't able to get at the time. So this is my reirradiation target in relation to the previous treatment plan. And you can see that my reirradiation target dips into the 80% isodose, and there's some 80% dipping in the region of the brainstem as well. So it was a valid question that I asked at the time, I think. So if we look back at my treatment plan from the 20 Gray and 5 fraction plan, this is what we gave. I don't really like it. The beam directions were chosen to try and avoid the previous treatment as best as possible. You can see that 95% of 20 Gray is going around about my target, not terribly conformally, and including the brainstem. And you can see that there's intermediate isodose going far and wide. So that's what we did. Don't love it, but that was kind of the best that we could do. And we thought that would be safe on the brainstem. If we then use our new tool, thanks to RayStation, and we replan 20 and 5, this time using our previous treatment as background dose, we allowed 25% recovery on the brainstem, and we said, let's limit the maximum dose to the brainstem to about 56 Gray EQD2, alpha beta 2. This is the plan that we get. So suddenly we've got a much more conformal plan. You can see that immediately. Some of our target is getting 20 Gray and 5 fractions, but appropriately, we have pulled off the brainstem in the area where we're most concerned about potential high dose overlap or overdosing due to cumulative dose. Now, nobody knows what these cumulative tolerances should be. Nobody knows how much recovery is correct, but these are kind of reasonable parameters that have been used, and you can reference them, therefore perhaps justify, but nobody knows. So with our tool, we could have given a higher dose and a more informed dose distribution thinking about our organ at risk, our brainstem in this case. As I said, we gave 20 and 5 because we assumed that absolutely had to be safe. If we say, well, let's say the cumulative tolerance is 56 gray, 25% recovery, what did we actually do? So this is the plan that I gave. And while 56 gray cumulative EQD2, alpha beta 2, 25% recovery, while that might be okay, it certainly wasn't what I anticipated the brainstem would have received. That's higher than I thought my safe option would have been. Replanning 20 gray and 5 fractions using our tool, you can see the 56 gray is pulled nicely off the brainstem and a much safer plan. But for glioblastoma reirradiation, actually, we prefer to try and give a higher dose. 35 gray and 10 fractions is the ballpark of where we like to sit. And in fact, with our tool, we can even get the dose up to there. So again, here's our target. You can see we've got a relatively conformal plan. We're getting bits of 35 and 10 in, bits of 95%, but again, appropriately, we're pulled off the rectum where we're concerned about that high cumulative dose. And if we look at our EQD2 56 gray isodose again, you can see we're pulling off the brainstem and protecting it appropriately. If we think about biologically effective doses, what are we actually doing to the tumour? Well, you can see for our 20 and 5 that I gave, we're giving some dose, not very conformally, plenty of the brainstem. More conformal if we plan it using our reirradiation tool in RayStation. But with our 35 gray and 10 fraction, we're giving a much higher biologically effective dose. This is alpha beta 10 EQD2, but you can see a much higher dose to our targets, but appropriately we're informed in terms of what we're doing to the brainstem. Again, we can see that on our DVHs. So here's my 20 and 5 manual plan, coverage much better with our RayStation 35 and 10 plan. And here's our brainstem, again, the manual plan, unwittingly giving high cumulative doses to the brainstem because we didn't have the knowledge. With the RayStation tool, we're able to sculpt the dose. We can give a higher dose to the tumour, but we can know that we're doing it more safely in terms of our organ at risk. It's been a huge cumulative effort. Chris and I have certainly enjoyed the journey. So thank you to the team in Leeds and thank you to the team at RaySearch as well. Thank you very much for listening.
So, I mean, this was really so nice to listen, both for me to hear, for us to hear Rasmus and Jakob talk about the upcoming release of RayStation, and then to hear the clinical side of this from Leeds. So now we're a bit short on time, but I was thinking that we should at least have some questions here in the Q&A. And then I will also ensure you that we will answer all the questions and get back to you. Even if we don't answer them here, we will get back to you after in some sort of post-event follow-up email. So first, I want to ask Jakob and Rasmus and I maybe, because based on the registration form that we had, and also the questions coming in the Q&A function, we see that there are a lot of concerns about handling of uncertainties in dose accumulation and deformable registration accuracy. And one thing that comes in is whether you can do this using rigid registration rather than deformable registration. And what you can do if you don't rely on the deformable registration in some regions. And let me first say that for the moment it is blocked to using deformable registration, but there is nothing that prevents you from creating a deformable registration with a zero vector field and then obtaining a sort of rigid registration. But preferably, and then I leave the word to Jakob, you should rather use an approach where you have deformable registration, which is good in certain regions, and in other regions you can use a different approach when you set up your objectives and constraints and clinical goals. Jakob, can you tell a bit more about that?
Yeah, sure. So I will share a slide, and this is almost the one that I showed before, but I skipped this due to time mostly. So what we have in our, I mentioned briefly some of our publications here. So you might go into this to see, sorry, lost window, sorry. So some of these publications, for example, the one on technical note on optimization function, shows how you can handle this by setting some of the optimization functions using like a worst case or a near maximum dose from your previous image. So this is in the research version of RayStation, and this is something that we are currently working on and hopefully will have in the future. But in the meantime, what we do support is that I mentioned briefly that we support this optimization function and clinical goals on EQD2, but only on the planned dose. So this means that now, for example, this clinical goal here on the sacral plexus is the near maximum EQD2, but for the plan only. And then you can actually assess this plan. And if you then assume that we have a worst case of like 30 gray in the previous plan, you can just sum them directly since this is an EQD2. So instead of doing this manual conversion between the EQD2, you can just make sure that you're staying away from EQD2, for example, below 50 gray or something, given the maximum dose that you have assumed in a point or some other worst case conservative estimate. So this is already a quite big leap. But hopefully we will have more, and we know that this is wanted for that you can have different optimization function and clinical goals, assuming some point-based or some worst kind optimization function for risk organs that you don't rely on your deformable administration using on. I'm not sure if Rasmus wants to add something.
No, not really. I think you explained that very well.
Great, then I stop sharing and see if Stina has some more questions.
The first question is if I'm able to share my screen. And this time I actually did it. Then I want to ask also a question to our teams in Leeds. I don't know if you have a good answer for this, but I know that we got in quite a lot of questions in advance regarding like how to think. So for instance, using high fractionation doses, if to take a choice between like SBRT or IMRT, and then how to think about tissue recovery. Are you like approaching some sort of protocol for how you do it in your clinic? I mean, I know that, for instance, we have this publication from University of Michigan where they have published what type of, say, recovery that they will use in standardized way. Louise, do you have anything to?
Yeah, I mean, it's a great question, and it's a really, really common question. I think nobody knows what the right answer is. Nobody knows. The Michigan reference, which I just put in the chat in response to somebody's question, that's what they do in Michigan, and they've treated a lot of patients with it, and they seem to be getting on okay. Nobody knows. In terms of hypofractionation and high doses per fraction, again, there are uncertainties as to how well the LQ model holds. There's a kind of school of thought that up to 9-10 grays per fraction, it's okay, probably not perfect. But remember, often your organs at risk are getting considerably less than that high dose per fraction. So the LQ model is probably more justified in the organ at risk setting when the dose per fraction is often not quite so high. But nobody knows. I think the best you can do is look at the literature and find a reference to back up what you think you want to do. But it's challenging, and that's why we need more research. Yep. Clinical trials, we need high quality data gathered so that it can be appropriately analysed, and we need the tools to perform appropriate analysis like that.
Yeah, I would just say as well, from the planning sort of team side, it's always helpful if these things are pre-agreed. So, you know, if the clinical team can get together and make a decision, then it will help the workflow even using this tool. Because if you don't know what everyone's going to want to use, you can't make templates, you can't make protocols. So probably with this tool, I think we'll probably need to look at some new clinical protocols and some new agreed sort of tables for these values. So it's probably helpful to do that.
Great to hear that. In interest of time, I will wrap this up now. It's really nice to hear your thoughts about this. Yes, no, I cannot even. Okay, here I am. So thanks a lot. And as a reminder, 2 reminders, there will be 2 more episodes of this webinar series. They will be during the autumn, and we will send out, we already have some sort of ideas on what they will be, but we will send out the details when we have it more defined. And also, we will answer all the questions that you have asked and follow up on those ones. Great. Thank you for coming and listening.
Thank you very much.
Thank you.